Good evening, everyone. Today, I am going to conduct a course on intersegment imaging, hidden clues and unseen tracers. We know that there are several limitations have been encountered with the reference standard of the gonioscopy for the angle assessment. Intersegment imaging provides non-invasive quantitative and qualitative evaluation of the interchamber angle as well as the pathology related to the sulcus and ciliary body. AS imaging has been shown to have performance in the angle closure detection compared to the gonioscopy. Imaging has greater reproducibility and better documentation. AS imaging enables better understanding of the underlying mechanisms of the angle closure and provides useful parameter for the risk assessment and possible prediction of the response to the laser and surgical intervention. Discussion with the illustration will be done during this course for the identification of various landmarks and the parameters, use of intersegment imaging for the visualization of the intra-blab structure will be also discussed. Course will be open for the third eye wherein technology meets clinical evaluation and opens up possibility towards the future of the glaucoma management. First talk will be by Dr. Prabhudesai Medha. As she is unable to attend this, she has sent the voiceover talk of her on the identification of various ACA landmarks and the quantification using the intersegment OCT. She is a director in Sight Vision Foundation at Pune, 20 plus years experience on the glaucoma management. She is also honorary assistant professor at Bharati Medical College, Pune. So let us hear what she has to say to us.
Good morning, everybody. I would like to thank APOS and AIOS for giving me this opportunity to speak on AS-OCT. Assessment of iridocorneal angle, gonioscopy is the gold standard. It needs contact lenses as well as contact with the patients. Expertise is needed and it gives us a qualitative assessment of the iridocorneal angle. UBM and OCT are other diagnostic modalities. They can overcome objective limitations. They are useful for documentation and useful in clinical practice and for research purposes. With OCT, we can obtain high resolution images of the anterior segment angle and structures, and qualitative and quantitative assessment of the angle is possible. Anterior segment OCC gives us assessment of the anterior segment structures involved in the pathogenesis of glaucoma. It provides images of the ocular tissues comparable to histology and comparable to those obtained with UBM. AS-OCT is more useful than UBM for serial monitoring of the angle. Alignment of ocular landmarks is possible with AS-OCT and also can capture video during the scan acquisition. So coming to gonioscopic diagrammatic representation, we all know that this is a corneal wedge here and this is the Schwalbe's line where it ends on the cornea. So this can be seen very well, and here there is a scleral spur which is an inward protrusion. So let's see on AS-OCT how to identify these structures. So this is a corneal wedge and this is Schwalbe's line here, and this inward protrusion is the scleral spur, and let's see all this in detail. So scleral spur is defined as the inward protrusion of the sclera, and there is a change in curvature of the corneal scleral junction. It is situated at the junction of the trabecular meshwork and the ciliary body. Schwalbe's line is defined as the posterior limbal zone bordering the cornea where the descemet membranes terminate. Length of TM, that is length LTM, is defined as the distance between the Schwalbe's line till the scleral spur. Schlem's canal is seen as a curvilinear lucent area external to the trabecular meshwork, and Schlem's canal is also seen from the SS to the anterior tip of the trabecular meshwork located at the end of the descemet. So bell, that is band of extracanalicular limbal lamina, is also seen It is defined as a hyporeflective band wrapping around the TM and SC. Previously, it was identified as TM shadow, but it is commonly seen in the open angles as compared to close angles. So, this is Bell. So, here you can see the hyporeflective band which is situated posterior to the trabeculum. So, coming to identifying these landmarks, this is the Schwalbe's line, here corneal wedge, this is the scleral spur, and here is the angle. Again, this is the corneal wedge, Schwalbe's line, scleral spur, and this is the angle, iridotrabecular angle. So, ocular biometrics, it can be quantified by AIOS2025 as predictors of primary angle closure disease. Static risk factors are the anatomical risk factors which can be measured on a single AIOS2025 image, and they are anterior chamber depth, anterior chamber width, lens vault, anterior vault, and so on. There are dynamic risk factors also which can be evoked by structural changes associated with pupillary dilatation or constriction. So, anterior chamber depth is the distance between the posterior corneal surface to the anterior lens curvature, and it is used to detect occludable angles in screening programs of primary angle closure. Anterior chamber width is a novel risk indicator for angle structure, and it is the distance between the two scleral spurs on the horizon. Coming to the static risk factor, that is lens vault, which is a novel parameter, and this is a perpendicular distance between the anterior pole of the lens and an imaginary horizontal line joining the two scleral spurs. It is independently associated with angle closure, and larger values are suggestive of increased crowding of the anterior chamber by a thick lens. Other static factors are anterior vault and RLV. So, anterior vault is anterior chamber depth plus lens vault, and RLV is LV divided by AV. RLV is a better indicator of primary angle closure than LV. In some studies, iris area, iris thickness, and iris curvature are also shown as risk factors, but they are not uniform in all meridians and hence cannot be considered for anterior chamber angle assessments. Angle opening distance is also an important factor, and AOD 500 and 750 microns can be measured. Angle recess area is a triangular area bounded by anterior iris surface and inner corneal scleral surface, and trabecular space area, that is TISA, is a trapezoidal area, and it is bounded between the scleral spur and the opposing iris. So, these are also indicators. So, quantitative parameters for occludable angles have been defined by various studies, but there is very little agreement between AOD 500 and TISA. Anterior chamber angle in degrees can be around 22 to 18, and this is very well accepted. Epithelium. So, dimensional analysis of the angle can be done. Circumferential assessment of the anterior chamber angle can be done. This has a moderate to good diagnostic performance in comparison to gonioscopy, and multiple scans, meridional scans are obtained. It is accurate and reproducible, and can quantify the amount of circumferential iridotrabecular contact and the amount of peripheral antisynchy. So, here the red circle is the scleral spur and the green line is the end point of iridotrabecular contact. ITC can be measured as this blue area, and it can be documented, it is reproducible, and change in the ITC index also can be measured post PI. So, HRSD is the high risk angle closure, and there have been studies. So, TIA, that is trabecular iris angle, if it is less than 12 degrees in more than 3 quadrants, the eyes are identified as high risk. Prevalence of HRS increases with age, and higher is among women. The mixed mechanism was the most common in this study among eyes with HRS. So, different mechanisms are possible for angle closure, and they can be pupillary block mechanism, plateau iris mechanism, thick peripheral iris roll mechanism, or exaggerated lens vault mechanism. So, here there is a pupillary block mechanism, and you can see the narrowing of the ankle closure, almost oppositional angle closure is there. Plateau iris mechanism is seen in this patient. This is thick central iris as well as thick peripheral iris, which is occluding the angle. Exaggerated lens vault mechanism is seen in this patient. This is a mixed mechanism which has lens vault as well as pupillary block mechanism, which causing narrowing of the trabeculoiris angle. So here you can see photopic pupil and angle. The angle appears open here, but after dark adaptation the pupil is dilated and you can see the angle is blocked peripherally. This is a patient of pigmentary glaucoma, which is where the concave iris is shown beautifully in AIOS2025-IC245-Anterior. This is a patient of primary angle closure. Oppositional angle closure is seen. This is post PI. The angle has been opened up to some extent. And here you can see before dilatation the PI is open, and this is post dilatation also, the angle is open still. Angle dysgenesis also can be very well documented with the help of AIOS2025-OCT. In NVG, peripheral anterior synechiae can be documented. Even after the implant of AGV, you can see where the exact AGV implant is situated, whether it is touching the endothelium or not, and the subscleral course of the tube also. So AIOS2025 has great potential for identifying patients at risk in angle closure, offers certain advantages compared with gonioscopy. It is a non-contact technique, can be done in any lighting conditions, and patients at risk can be assessed with lights on and off, that is scotopic and photopic conditions, and the most important, it can be performed by a technician and can be interpreted by an ophthalmologist. It is definitely complementary to gonioscopy and not a replacement for gonioscopy. Thank you.
Thank you, Medha, for a very comprehensive and detailed on the intersegment imaging. Now, as she has said that the gonioscopy cannot be replaced, so we have a lecture by Dr. Devendra Sood. He will be talking on the angle evolution with the gonioscopy and what are its limitations. Dr. Sood doesn't need any introduction. He was president of Glaucoma Society of India, more than 30 years experience on practicing on the glaucoma patients, and he has done a lot of works on the angle closure glaucoma. Devendra, please.
Good morning, and thank you very much, Dr. Khamar, for this opportunity to be here. So whenever we see patients with glaucoma, the first step is that we need to confirm the diagnosis. And for that, we require the intraocular pressure, the optic nerve, the visual fields, and the gonioscopy findings. Because the gonioscopy findings will help us to identify the next step, that is to confirm the type of glaucoma the patient has. Because treatment is going to be based on the type of glaucoma. Gonioscopy here becomes very important. So it's easy to identify an angle. Can I have a pointer, please? So it's easy to identify an angle which is open or an angle. More importantly, I think we need to identify an angle which has open but has a tendency to close, because then the diagnosis will be angle closure. We need to be able to identify closed angles, and we are also concerned about angles which are neither open nor closed but narrow, because these angles will never close over a period of time. Some will, we need to be able to judge that. So the key to right glaucoma management actually requires that we make the right diagnosis. And for the right diagnosis, we need to do the gonioscopy. So the first thing is to choose the right lens. A Goldman single mirror or two mirror, or a Zeiss 4 mirror or a Sussman 4 mirror are good options. The Retina 4 mirror is not to be used for gonioscopy evaluation. Now, this is a case profile of one of our patients, a 46-year-old who had raised pressures of 33-46. She came to us, she was on brimonidine timolol combination. This is what she had a best corrected visual acuity of 6.6, cornea adjusted pressures are 20, front of the eye looked like this, and when we did the gonioscopy with the 4 mirror, we found that the mid peripheral iris was bowing anteriorly, and there were actually, you can see some synechiae here. But when we did the gonioscopy with the 2 mirror, the Goldman 2 mirror, we found that there was an incomplete separation of the iris, And you can actually see that what we were looking at was a mesodermal dysgenesis of the angle. So the diagnosis here was not angle closure as was evident from the foremirror, but was actually mesodermal dysgenesis. This patient also had a maxillary hypoplasia, but no dental changes. The second thing we got to look at is the technique by which we are doing gonioscopy. So patient should be looking in primary position, light should be dim, and the size of the contact lens should be such that there's no compression, and similarly we should not be pressing by asking the patient to look down or in a different direction. Initial evaluation is always in a primary position. Then if you see an angle which is open, you reduce the width of the beam to see if you can get this angle to close. So you can see that this angle is open here. You can see the ciliary body band, but as the beam width is being reduced, it has actually gone into a closure. So this patient with open angles actually had angle closure. The other thing is when you see an angle which is closed, you ask yourself, can I get this angle to open up? And this was more important when laser iridotomies were not available and surgical iridectomies used to be done. So they needed to differentiate. If they saw synechiae, they said, we'll do a trabeculectomy. If it was appositional closure, they opted for a surgical iridectomy. So this is where indentation is also done. The other thing in gonioscopy is to identify structure. So easy to identify the ciliary body band as a gray structure with a variable amount of pigment, which you see here. Then you could identify just anterior to that the scleral spur, and then just anterior to that will be the trabecular meshwork. One of the points of concern would be when you see multiple layers of pigmentation in the angle, then the posterior most layer represents the trabecular meshwork. So you see a pigmented layer here, 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 and here. So this is actually the trabecular meshwork. Again, just anterior to the trabecular meshwork is the Schwalbe's line represented by the yellow marker here. The important thing is you can create the corneal wedge, but I have never been able to take a good picture of the wedge. So this is perhaps the only picture I have. The apex of the wedge represents where the corneal Schwalbe's line is. Another situation where we can see here is that there is a widening of the trabecular meshwork. More importantly, look at this nature of the pigmentation that you're seeing here. Pigmentation of the trabecular meshwork is fine and diffuse, while pigmentation on the Schwalbe's line is more coarser, like a pepper granules. And this is also called as a Sampolosi's line in pigmentary glaucomas. The other thing we look at is Schlemm's line, which is actually a widening of the trabecular meshwork, and you can get a reflux of blood into Schlemm's canal. Typically see them in patients who have a raised episcleral venous pressure. So again, just to show you Sampolosi's line in a patient with pigmentary glaucoma, very coarse nature of the iris pigment granules on the Schwalbe's line. Then you see patchy pigment on Schwalbe's line here, which is suggestive of past closure, even though you can actually see the ciliary body band in bits and pieces. Same thing again here. Angle is nice, wide and open, but this patchy pigment is a telltale sign that this angle has a tendency to close. We can even pick up blood vessels in the angle, and pathological blood vessels are those which cross the scleral spur. Contour is important. You see a concavity of the iris insertion in myopes, aphakics, and developmental glaucomas, and peripheral convexity in patients with angle closure. So this is important. It's important to grade. Now the problem in grading is an open angle and a closed angle is easy to identify. Your technique should be right, but grading is very important. Now there are multiple systems of grading. In one system, 0 represents closure, and in another system, 0 represents open angle. So whatever system you follow must be documented so that the person who sees the patient after you knows what is happening. A simpler way to do it is to base it on the structures that you are seeing. For example, posterior most structure seen here is ciliary body band. You mark on the goniogram ciliary body band, then see if you can get this angle to close. As I've been showing you repeatedly, it has closed. So on the goniogram, you represented ciliary body band with a tendency to close. So your diagnosis here will be angle closure. You can mark out other telltale signs like a goniosynechiae as you're seeing here as a representation on the goniogram. And if you see an angle which is closed, you got to see if you can get it to open by asking the patient to look in the direction of the mirror and document accordingly. Now all narrow angles do not close, so we need to differentiate between those which can and those which will not. So the important thing is asymptomatic closure is common, and a gonioscopy must be done for all our patients or glaucoma suspects. To assess occludability in patients, we must make sure that our technique is right. Open angles, do they have a tendency to close? Look for goniosynechiae, patchy pigmentation on Schwalbe's line, and the classical on-off sign where you see this angle narrowing further as light was being reduced, and there's a peripheral convexity of the iris which is happening here. So gonioscopy is a very simple technique. It's inexpensive, and that's where the problem lies. Because it's inexpensive, we as ophthalmologists don't value it, and we are not able to transfer this value of this procedure to our patients. It's subjective, and it involves contact with the eye, so there's a coupling media which is used. More importantly, illumination is required as compared to the UBM, and therefore there is a possibility of the angle status changing, routinely not being done as a procedure, and therefore we have difficulty in identifying. So it's not being done and it's not being taught, and therefore the problem happens. And again, being subjective, what may be open or occludable for me may not be for another person. So that's again a problem that we have. Thank you very much.
Thank you, Devan. It was a very nice presentation.
Thank you, ma'am.
But we have to say that anterior-segment imaging is also good technique. So
That wasn't the topic given to me, ma'am.
yeah. So the next talk will be.
Yeah. So now I invite Dr. Mayuri Madam for her talk on anterior segment imaging and primary angle closure disease.
That's it. So I will be talking on anterior segment imaging in primary angle closure glaucoma, how it is going to help us. The clinical examination of ACA, angle closure angle, anterior chamber angle by gonioscopy is essential in the evaluation of glaucoma patient, but it is qualitative and subjective assessment that is prone to have a variability between the two examiners. Imaging devices provide a more objective assessment of ACA. Because of the consistency of the image generated is far better as well as reproducible at any time, anterior segment imaging has a place in the glaucoma management. Because OCT images can be obtained in a completely dark environment, this method allows greater sensitivity in identifying the eyes with the oppositional angle closure. The landmark is already been shown by Dr. Mehta, but first we have to identify the scleral spur, and then the trabecular area and angle recess as shown here. Various measurements can be obtained by using various softwares that are available with the imaging. Iridocorneal tool is a very, very important tool as shown here, and it's been described by Mehta, so I will not go into the detail, but iridocorneal angle metrics can be in the form of angle opening distance at 500 or 750 micron from the scleral spur. Angle recess area can be measured, and the TISA or the trabecular iris surface area which is polygonal in the shape can be at the 500 and 750 micron. These all metrics can be used when you are doing some academic trials. Now I will describe various uses of AIS imaging and PSEG. First is to know the extent and the mechanism of angle closure, and then the physiological variation of the angle. So first, as shown here, it could be a pupillary block mechanism. You can see the convex iris configuration here with the lens which has moved forward, or it could be a large lens giving the phacomorphic element, or it could be a tapered appearance of the plateau iris configuration. UBM can give you the another important finding in this, where exactly is the insertion of the iris on the ciliary process or into the angle. Here it is shown to have an anterior insertion of the iris. If patient has acute attack, it could be because of the ciliary effusion, or ciliary effusion can be associated with the angle closure. So this is very well seen. The inflammatory cells are seen in the antechamber, which is very shallow. There is a total angle occlusion by the convex iris configuration, and you can see a ciliary body effusion in this area. The same is also seen nicely with the UBM. The ciliary effusion, as I said, could be one of the contributing factor to the angle closure element. So choroidal expansion might precede or contribute to the primary angle closure attack, although it is unclear which comes first, shallow AC or the uveal effusion in the eyes with a primary angle closure. Various studies are there to show that there is a higher choroidal thickness in the antechamber group, angle closure group, compared to the POAG group. Another study has also shown that there is an anterochoroidal thickness which has increased in the primary angle closure glaucoma compared to the primary angle closure eye disease. So higher choroidal thickness in the fellow eye of the patient, this is very important. In the fellow eye of the patient with the acute primary angle closure glaucoma is also been seen. The lens vault is already been described. It's a crystalline lens rise tool which is available with the all machine now. So it helps in assessing the amount of lens rise relative to the antechamber depth, which should be calculated from the scleral spur to scleral spur and the antechamber depth. And one can determine the likelihood of the success in opening the angle by removing the crystalline lens. Then posterior pushing mechanism of angle closure is very well explained here. It's a case of spherophakia. The small round lens has pushed the iris forward. And here on the bottom, it has been shown that iridectomy is done in this patient. Maybe it has a no value in this type of angle closure posterior pushing mechanism. The pigmentary glaucoma can have a reverse pupillary block. It has also been nicely shown here that you can see the reverse pupillary concavity of the iris and touching the lens, giving you the reverse pupillary block. The ciliary body cyst or the iris cyst can nicely be documented by using, and that could be the reason for the angle closure in this particular case, or malposition or dislocated IOL can also give you the angle closure. Another use of this imaging is to understand the physiological variation of the angle. I've said in the beginning of my lecture, this technology can be used even in the dark. So we used to, when I was resident, we used to do dark room prone test for the diagnosis of angle closure. But now with this technology, it may not be required. Like this is a classic example with the lights on the pupillary area. You have a small pupil and you can see a clear angle here, though it appears to be narrow angle. And now with the closing of the light, you can see the opposition here and narrowing of the angle. So dynamic changes can easily be visualized by using this technology, and this indicates the prophylactic iridectomy in this eye. Now there is a change in the concept of primary angle closure glaucoma. AIOS2025 is also an excellent tool to measure the iris parameter, which cannot be measured with the gonioscopy. So increase in the iris curvature, area or thickness has been shown to be independently associated with the narrow angle eyes. And you can also calculate the volume as well as configuration on dilatation of the pupil. So we all know that the all occludable angle may not have an angle closure. So the iris volume which increases after the pupil dilatation in the narrow angle eyes, particularly last row of iris, they are the eyes predisposed to have an acute angle closure glaucoma. So oppositional angle closure with the angle opening distance of 5 degrees or less, these people needs laser PI. If the angles are 5 to 10 degrees, laser can be recommended. If there is an anterior lens vault, which is sufficiently large, then cataract extraction may be of use in the opening up this angle. But if you have a persistent narrow angle, even after laser iridectomy, or this could be play to iris syndrome, or you can utilize the UBM and see what is the type of ciliary processes this patient has, or the processes which are in contact with the peripheral iris. Post-traumatic glaucoma, on gonioscopy you can see the good angle recession, but this technology also helps you in giving the good pictures of the extent and amount of cyclodialysis cleft or the iridodialysis or the angle recession. So pseudophakic glaucoma, Dr. Mariam is going to discuss, so I will not discuss in detail, but you can identify where exactly is the loop of that IOL. This is a case where the young female had a family history positive in father. On the gonioscopy, the angles were narrow. On indentation, it opens through 2 or 3. You can see the patchy pigments also. And with the OCT also, we see that there is a narrowing of the angle. So this patient needs prophylactic laser PI. So it is also useful in assessment and monitoring in the opaque cornea like this patient. One eye has a corneal opacity, PKP is planned, other eye had a laser iridotomy. So we did the AIOS2025-IC245-Anterior to find out the angle, and it was open angle, so proceeded with the PKP. It also helps in the assessment of the procedural or surgical outcome. Here, after PI, you can see the deepening of angle, and there is a clear gush of the aqueous into the anterior chamber. ACD also deepened. And with the dense AI, arcus analysis, it is difficult to appreciate whether it is a full thickness PI or not. So with this, you can identify. And the corneal opacity Peters anomaly, you can see exactly where exactly is the angle and the synecdoche. And this is the graph failure. We found out that it was a close angle with multiple PIs. So the limitation of the technology cannot be done in very young children, cannot go through the iris. So the ciliary body and the other details cannot be seen, and the movement artifacts can be there. So, and wearing a soft contact lens when the OCT scan is performed has no effect on the imaging quality. So useful technique to understand the physiology variation and many other things. Thank you.
Thank you, madam, for elaborating the use of anterior segment OCT and UBM in angle closure disease. Now I invite Dr. Mariam Mansoori for describing the role of anterior segment imaging in pseudophakic glaucomas.
Good morning, everyone. I am thankful to Dr. Mayuri and AIOS for giving me this opportunity to speak about the role of anterior segment imaging in pseudophakic glaucoma. The pseudophakic glaucoma is a secondary glaucoma in which IOP is elevated following cataract removal, provided no glaucoma prior to cataract removal. Understanding etiology of the pseudophakic glaucoma is crucial for its effective management. Anterior segment imaging provides non-invasive, high-definition, reliable, and repeatable cross-sectional images of the iris, IOL, zonules, and ciliary body. Accuracy and ability to visualize behind the cloudy and opaque cornea is possible with the UBM, and it allows the assessment of the anterior segment pathology and find out the causes of raised IOP. The causes of pseudophakic glaucoma include the IOL-related causes are the haptic-induced and the decentered and tilted IOL. Inflammatory causes, the peripheral anterior synechia, posterior synechia, haptic-induced uveitis, and neovascular glaucoma. Lens particle and foreign material causes also raised IOP, that is vitreous in AC, lens particle, somarine, ring, silicon oil in the anterior chamber. And others are the aqueous misdirection syndrome, capsular block syndrome, and the UGS syndrome. So first we will take the IOL causes. In this patient, the cornea is opaque, and when we did the UBM, there is a anterior chamber IOL and also the posterior chamber IOL. Both IOL in the same eye, and it causes the edema of the cornea and the raised intraocular pressure. Here the pieces of the haptic of the AC IOL in the angle, and this causes the irritation, inflammation, and raised intraocular pressure. In tilted IOL, there is a misplaced haptics. that may irritate the structure and cause inflammation of the angle structure. Here this haptic is in the sulcus and this is in the bag. And here you can see this is the anterior segment OCT, this is in the bag, and this is the sulcus fixated lenses. And when there is a re-dialing is done, this patient having both the haptics in the bag, and there is we treated the raised intraocular pressure. This is the sulcus IOL, and that causes the irritation and the raised IOP. This is the anterior segment OCT pictures and shows both the haptics in the sulcus. There is a peripheral anterior synechia. There is this IOL pushes the iris forward and causes the peripheral anterior synechia. Here also there is a anterior synechia, and this causes the raised IOP. The sulcus IOL with the pupillary block. Here you can see that there is a pupillary block, and so it causes the raised intraocular pressure. In this patient, you can see there is a pupillary blocks and the iris bombi, and there is a peripheral anterior synechia and anterior synechia and causes the raised intraocular pressure. The uveitic glaucoma, you can see on the gonioscopy there is a inflammation, and there you see the broad peripheral anterior synechia. So this is the broad peripheral anterior synechia. Here is the cyclitic membrane, and it causes the pupillary block, and there is a raised intraocular pressure. In the neovascular glaucoma, when the cornea is very hazy, we can't see anything, then you can see that patient is having the pulling by the pulling mechanism, because the fibrovascular membrane pulls the iris forward, and you can see here there is a pulling of the iris. And even if you see the ciliary body here, it is not seen very clearly, but the ciliary sulcus is absent in cases of this type of glaucoma. No, not in this patient, sorry. There is a hyphema you can see here. In this patient, there is a optic capture, inferior iridodialis and the vitreous in the AC. But we are not able to see on the slit lamp very well that vitreous in the AC. So when we did this UBM, there is a vitreous in the anterior chamber. It causes the irritation and raised intraocular pressure. The Sommering's ring also causes the raised intraocular pressure. You can see this is the Sommering's ring, pushes the iris forward, ciliary processes and iris forward and causes the synechia formation. So this is the massive Sommering's ring, and that is extending from the IOL optics to the ciliary processes. And with these ciliary processes were displaced anteriorly, and there is a closure of this angle of the anterior chamber. And after Nd:YAG laser photodisruption of this capsule, you can see the Sommering's ring moved posteriorly, and the layers of ring become loose, and also there is a resolution of the pupillary block and the anterior rotation of the ciliary processes, which are rotated anteriorly, will go back, and there is we treat the raised intraocular pressure. There is a silicone oil bubble in the anterior chamber. In this patient, the silicone oil is removed, but still there is a silicone oil in the anterior chamber. So when we did the UBM, the bubble will be in the center, and it blocks the pupil and causes the raised intraocular pressure. Even if we do the gonioscopy, then the emulsified silicone oil can also be seen in the angle in this type of patients. In the malignant glaucoma, the aqueous misdirection syndrome, you can see there is the whole iris lens diaphragm pushed forward, and there is a flat anterior chamber. So here you can see that is a flat anterior chamber. The neovascular glaucoma misdiagnosed as the malignant glaucoma. This patient, 64 years old, referred to us as diagnosed as the malignant glaucoma following cataract surgery. When patient came to us, the peripheral peripheral anterior chamber is shallow, but in the center the AC is firm. So we did the slit lamp examination, and I saw that there is a ectropion UVI. No new vessels are seen, but ectropion UVI. So we did the UBM, and you can see that by the fibrovascular membrane of the neovascular glaucoma pull this iris forward, and it causes the angle closure. And ND-YAG laser photodisruption of the anterior hyaloid face causes the resolution of the pseudophakic malignant glaucoma. So it is useful to know whether it is malignant glaucoma or the neovascular glaucoma. So the treatment is different of the malignant glaucoma and the neovascular glaucoma. So in malignant glaucoma, you can do the anterior hyaloidectomy. Evaluation in the opaque cornea. Whenever there is a cornea opaque, then we can't see what is the reason for raised IOP. Here you can see that the silicone oil is in the anterior chamber and there are no structures seen behind. So this patient, the cause of rise in intraocular pressure is the silicone oil in the anterior chamber. And in this is a corneal opacity, and when we did the UBM, there is a anterior pulling of the iris, and that is a neovascular glaucoma. When there is a pseudophakic bullous keratopathy with glaucoma, we see that the patient is having an anterior chamber IOL behind the opaque cornea, and so it causes the irritation and there is a raised intraocular pressure. So UBM facilitates accurate diagnosis of the underlying causes of pseudophakic glaucoma by providing high resolution images of the anterior segment. This precision allows the targeted intervention such as repositioning in a malpositioned IOL, removing residual lens material, managing synechia, ND-YAG capsulotomy and anterior hyaloidectomy in the malignant glaucoma, and thereby improving the patient's outcome. So UBM can detect changes that can't be detected by clinical examination and recommended in all cases of pseudophakic glaucoma for better evaluation of the underlying causes, which helps in subsequent management. Thank you for patiently hearing.
Wonderful talk.
Thank you.
We have maybe if time permits, you should tell us the tricks for how you can do such a beautiful UBM.
These pictures are our own, all pictures are.
So
Only the scientist segment OCT is given by Mayuri, otherwise all pictures are from
We do a lot of UBM as well as anterior segment, particularly whenever there is a pseudophakic glaucoma. With the fully dilated pupil, it is, of course, you can identify the one haptic in the sulcus and all. But pediatric age group, I have done a lot of work on that. By doing the UVM, you can identify where exactly is the mechanism of which is causing the glaucoma, particularly in children, microphthalmic eyes, the rotation and malformation of ciliary body. Everything is so beautifully visible, but it is not in this particular session, so but you can do it. We will take all the questions at the end of all talk.
So till now, we learnt about how anterior segment imaging plays a role in diagnosis and clinical decision making. Now we'll hear from Dr. Mayuri how imaging also helps in evaluating the post-trabeculectomy scenarios.
Again, thank you everyone for being here at these early hours and so many halls going on. So I will be talking on how anterior segment imaging helps in post-anti-glaucoma surgeries. Trabeculectomy is still the most effective filtering surgery, even though more and more surgical options and MIGS are now available. And the long-term data shows efficient control of IOP up to 67% of initially successful trabeculectomy after 15 years. So in the follow-up care of these patients, the ophthalmologists focus on the bleb as a functional part of the trabeculectomy. Various useful classification systems are developed to identify the filtering bleb according to the morphology and parameters can assist the clinician in decision making, but the clinical evaluation of this patient can be challenging. So this is to show you the natural history of the bleb, what happens. So earlier in the first after 3 weeks or 4 weeks, it starts showing the failure if it is there. By the end of 3 to 6 months, it is stabilized, and then it is status quo. So, blab morphology is known to be an important indicator for the blab function. Morphil classification every one of us are using. It describes the area of the blab, height of the blab, and vascularity. The Indiana blab morphology classification has also included the leaking or the Seidel test, and the AMBAG's classification not only see the height, vascularity, but also describes the transparency of the blab. And this all will help us in guiding which are going to be a successful blabs. So the imaging of trabeculectomy blab is not a new thing. It's been using AIOS2025 for this, and it is a promising tool to imaging the trabeculectomy blab in a very early stage of the operation. It was able to demonstrate the features of the blab morphology which are not visible with the slit lamp. So assessment of filtering blab in vivo or the functionality is possible using this technology. This is a classic section to show you AS imaging of the blab. Here you can see the subconjunctival fluid space, wall blab, a wall of the blab, then the scleral flap here, sclerotomy opening, and the root beneath the sclerotomy flap, iridectomy, and suprascleral fluid spaces. So I will describe all this in the later part. So ideal blab should be good if it is a vascularity is similar to the surrounding conjunctiva. It has to be have numerous microcystic areas. It should be diffuse and with a moderate elevation. This is the slit lamp picture, and it is better you visualize if you use the AS imaging. So similar looking blabs on the slit lamp can have a different presentation on the AIOS2025. This is a spongy liquid blab. This has a big aqueous areas and a thin cystic areas in this area, and this is also having different morphology. Sometimes this avascular moderately elevated blab looks like a good blab, but it is deceptive. This blab has a very dense homogeneous area, and these are the blabs which may not have a good functionality. So vascularization and fibroplasia in the subconjunctival area and or the episcleral space are one of the or main cause for the blab failure, and sometimes it could be the obstruction of the internal ostium. So coming back to the first slide, can we predict this blab failure? Can we recognize it early? Can we prevent by diagnosing this early and manage it in a better way? So the most important step in the management of failing blab is to recognize its presence. And for this aim, we conducted a study to correlate the morphological feature of blab on AIOS2025 at 1 month with the blab functionality or the surgical success at 6 months. So what we did post-operatively, we took the two sections, radial sections and tangential structure at the most elevated area of the blab away from the limbus. The blab wall reflectivity was identified. Uniform reflectivity is shown here. And this is the multiform blab wall reflectivity, which has a multiple tiny cavities of aqueous drainage. Hyperreflectivity is suggested in a form of dense white area, which is not good for the success. Now, multiple blab wall reflectivity is again identified into multiple internal layers, subconjunctival separation as shown here, or microcyst areas. And these are the blabs which are ideal for this success. Root beneath this scleral flap has to be identified. Now, at the conclusion of our study, we identified various patterns, blab patterns, microcyst plus multiple layers, microcyst with the subconjunctival separation, only microcyst, and uniform blabs. And it was obvious from our study that this is the area which has 100% success at the end of the 6 months. So we can predict At 1 month for the long-term subsets, if the bleb wall with the multiple reflectivity shows increased chance of the success at 6 months, bleb pattern with the multiple internal layers and microcyst could be ideal for the success of this success. This is a Japanese study. They also are having the same criteria, but they also included the width of filtering opening seen on the AIOS as a success. Now, two eyes bleb may behave differently. This is a left eye bleb and this is a right eye bleb. So, in early case, this is one case where at the end of 10 days, patient showed rise in the pressure, 14 millimeter of mercury, and the bleb appeared to be flat. So what we should do? Do we remove the releasable suture? And this is the OCT finding showing you homogeneous area. So we release the bleb, and immediately you can see there is a multicystic formation, elevation, and this is how we have a successful trab. So, but with the mitomycin C use, we know there are so many problems. So we need a safer option. So biodegradable implants collagen was there, not now, which is leaving in its place a fibrous sponge, the negative copy of the original one, by the 19 to 180 days or more. So we studied this also. So this is a homogeneous implant seen immediately after the surgery. And at the end of 6 months, there was a complete absorption of this implant. So this is day 1. There is an anoic area here, and this is homogeneous implant. After 3 months, you can see the shrinkage of the implant here, and new areas of anoic space is coming up here. And at the end of 6 months, there is a total shrinkage with a large anoic area in this subscleral space rather than in the subconjunctival area, and few microcystic space away from this homogeneous area. Expressions, you can identify where exactly is the position, and you can evaluate the bleb. The tenon cyst, this is what it was with the 26 millimeter of mercury and 2 millimeter height. And after needling, you can see the flattening of the bleb area. At the 6 months, still there was a single cavity, and cyst size was 0.6 millimeter. You can also identify the positioning of the tube, where exactly it is, away from the iris or the cornea, or exactly you can localize the pathway. So implication is, for the better understanding of the bleb morphology, you can predict the failure or success at early postoperative period. So you can use either early intervention in form of enhancement of steroid, 5-FU or MMC injection, needling, and release the suture. So limitation, vascularity of bleb and leaking cannot be identified using this technology, and difficult in children. So it is useful modality for evaluating the natural history of any implant that you are using or predicting long-term success. Thank you.
Thank you, Mayuri, for wonderful photographs of the various types of blebs. Now I invite Dr. Purvi Bhagat. She is a professor and head of the department in the Western Regional MNJ Institute of Ophthalmology. Yesterday only she received the honorary FACO award, and in the next session she is going to get the International Heroes Award. So
Thank you, madam. Thank you, and thank you, Dr. Mayuri, madam, for including me in this IC, and of course to AIOC for considering this IC in this prestigious event. So what I'll be talking on is kind of basically going to be an overview, somewhat an overlap, and a summary of the entire session that has been discussed, and a little something beyond that. So it will be considering what is the present day status of anterior segment imaging in glaucoma practice. So if you are looking for more amount of objectivity, because that is what we heard from Dr. Sood sir, that gonioscopy, one of the limitations is it is a subjective test. So if you are looking for more amount of objectivity with a reproducibility, you are looking for different measurements with great precision, you are looking for calculations, And if you are looking for practicing teleophthalmology, telemedicine, storage of data, use of softwares, then anterior segment imaging is the way to go. You may have cases like this. Significant corneal edema, gonioscopy, of course, is not going to play any role here. So here, anterior segment imaging, as we have seen, plays an important role. It tells you whether it is just a pupillary block with iris bombay, convex iris configuration, or it is actually a synechial closure. In different kinds of occludability also, you can see these different types of iris insertion. So that will also help you in clinical decision making, the diagnosis, and whether you want to do a PI for this patient or not. It also helps in the darkroom provocative test. Again, you have seen an occludable angle on gonioscopy. You are not very sure whether you want to do a PI for this patient or not. So you can do the tests, either it could be AIOS2025 or it could be UBM, under lighted conditions and under dark conditions, and you can see how the configuration changes. So this is not only helpful for you in the clinical decision making that yes, this patient needs a PI, but it also helps in patient education, because these kinds of imaging, when you show to the images you show to the patient, it's very easy to counsel them and show them that if you don't undergo PI, you might land up in an emergency. Cases like this, it's very easy to confirm that the PI is patent. It's a very mid-peripheral and a large PI, there's no doubt about it. But when you do the gonioscopy, sometimes you are not very sure how much the angles have actually opened up. So that quantification of your success which you are looking for is missing. So here, biometry with the AS imaging plays an important role. You can do different calculations. You can produce reproducible criteria. You can document change either longitudinally over time or with your treatment. And you can again identify the at-risk population in whom you would want to do some interventions. Cases like this, there is a PI but hidden under the dark arcus senilis. You are not sure whether it is patent or not. So you do an imaging technique, and it could be again OCT or UBM, and you can see very well how it is nicely patent here, but here there is still an iris tissue left which needs to be perforated. Lens volt, again very important. You will see this volcano type of a sign or a Mount Fuji sign on gonioscopy, and you measure the lens thickness and the lens volt. That is the distance of the anterior pole of the lens from this horizontal line joining the two scleral spurs. So this will tell you whether the lens is actually playing an important role in the angle closure and its removal will help or not. For example, these cases AC is very shallow, the lens volt is very high, and in these cases if you do the lens extraction, of course the entire scenario and anatomy will change. But on the other hand, if the lens volt is not significant, you can see here the angles are already open, the lens volt is not significant. So in these cases, if you consider that your lens removal is going to help, you are making a wrong decision. Again, pigment dispersion, not very difficult to diagnose on gonioscopy. You will see the sample-lysis line, you will see the mascara line on the trabecular meshwork or concave iris configuration. But sometimes imaging helps in additional information. You can see here a very concave iris configuration. You can see the iridolenticular touch, and here even it's in touch with the zonules. It's not visible on screen, but the zonular fibers are there. So basically it's in touch with the zonules and the lens. So PI is always a dilemma and a debate whether it should be done in pigment dispersion syndrome. But in these cases, if you do a PI, it definitely helps to reverse the entire anatomical configuration. So it helps to halt the progress of the condition. You can see how the entire anatomy has changed. Again, cases like this, UBM plays a very important role. Post-trauma, you can see those cyclodialysis clefts. Sometimes post-trabeculectomy also. You have unexplained hypotony post-surgery, and you do a UBM and you can see those clefts which can explain the condition. Sometimes on gonioscopy you can just see synechia formation, but when you do an imaging you can find that behind that synechia there could be angle recessions or cyclodialysis. Foreign bodies, again, very important. It will help you to determine your mode of treatment, how to approach that foreign body, what tissues it is traumatizing, and how to manage the case. An added advantage of UBM is cases of pseudo-exfoliation. You can see all those dandruff-like material over the zonules everywhere. And here you can see this laxicity of the zonules also, and you can see these broken zonules. So if you're planning for cataract surgery in these cases, all these investigations and images, they help you to manage and prepare your case accordingly. A case of subluxation of the lens, you can see how grossly it is subluxated. It's a large lens and totally closed angle on one side. And sometimes in spherophakia, you can even do the biometry. So it will help you to diagnose whether what type of a lens it is, and again manage a cataract surgery accordingly. Malignant glaucoma, again, UBM plays an important role. If it is a case of malignant glaucoma, it will be totally everything is flat and shut down. There will be no sulcus, no posterior chamber formation. Whereas if it was a case of simple pupillary block, you can see the presence of the posterior chamber. You do a gonioscopy, you can sometimes see these peripheral humps, you can see lumps, elevations. So you are almost sure that there is something behind the iris there which is causing these elevations. So you do the UBM and you can see how anteriorly rotated these ciliary bodies are, which is causing those peripheral hump formations. So a typical case of plateau iris. Or sometimes there could be cysts, masses, or tumors behind the iris, which are causing those peripheral humps. So these are cases of pseudo-plateau iris. In these cases, again, imaging helps to know the origin, from where it is arising, what is the content. Here you can see it's a cystic formation, and here you can see these are melanomas. You can see the extent and whether it is progressing or regressing over time or with treatment. Functional status of the bleb we have just seen. In addition, imaging, it helps you to decide where you should take your compression sutures in overfiltering blebs, which blebs are likely to be more responsive for needling, to evaluate your bleb changes after suture modifications, either lysis or release or adjustment, and in planning of bleb revision surgeries. We do a lot of shunts and tubes now, so sometimes on slit lamps it is difficult to gauge whether it's actually touching the cornea or the iris. So when you take a cross section with these imaging techniques, it actually helps to clarify whether it is actually touching any of the tissues, and any modification of the tube placement needs to be done. Coming now to the newer advances that are there in the present day, we now have the swept source OCT, which allows a three-dimensional 360-degree analysis of the entire angle, and it is very, very helpful for, again, patient education and for clinical decision making, and all these structures are visualized in a very high resolution. An added advantage of swept source OCT is that it has a great amount of reproducibility and objectivity, and it allows you to measure the iris trabecular index, which is actually a measure of the extent of angle closure, and also identify the peripheral anterior synechia. For example, this red line is depicted as the scleral spur. So anything that lies above shows the area of contact. So here you can see the entire angle, everything is above that scleral spur, and you can see this blue zone. It again depicts the amount of iridotrabecular contact. So here it's a 100% closed angle, whereas here there are just isolated elevations which shows some amount of iridotrabecular contact. So this is a very major advantage of the swept source OCT. We also now have the ICAM, which is a gonioscopy assisted imaging, which also allows three-dimensional, very high resolution, high magnification, true color view images of the entire angle. So small and fine things like pigmentation, neovascularization, small synechia, which can otherwise not be picked up in the conventional AIOS2025-IC245-Anterior, can be picked up with the ICAM. You can also do the surface imaging like Schlemm-Flug imaging, scanning slit lamp systems, in vivo confocal microscopy, where you can have very high resolution images of the anterior chamber and mainly of the cornea. So if you're planning for refractive and cataract surgery in glaucoma patients, in pseudo-exfoliation, you want to study the effect of drugs in these eye, you want to see whether your trab is going to be affected by any surface changes, then you can do these surface imaging techniques. But these are not effective for angle imaging or beyond. This is just mainly for the cornea. Everything now in the field of investigations is associated with the AI developments. So even in AIOS2025, AI-assisted techniques are now there which can actually assess or improve the image quality that you have received. They help in image classification and analysis. We have seen in the first lecture, those who were present, that scleral spur is the key anatomical landmark which helps you to define angle closure and do all the biometry of the angle. But the manual annotation of scleral spur is very difficult. It is subjective, it is time consuming, and sometimes may not be possible also, especially if there is angle closure, synechias and all those things. So now AI incorporated in the AIOS2025 helps you to actually objectively detect the scleral spur and do all the calculations. AI can also help you to predict the efficacy of laser PI in angle closure suspects. So it will actually tell you how the angle is going to change over time, just like you have the VFI in Humphrey fields. It actually helps you to understand how the angles will progress over time, do a trend-based analysis, and whether doing a PI will make any changes. So it helps you to optimize the patient selection and also avoid any unnecessary interventions. So to conclude, if you are looking for sensitivity in angle closure and study angle closure in details, OCT has better results. But if you are looking for the greatest range of anatomical information, study the ciliary body, study the lens well, study the zonules, then UBM is the way to go. So ASOCT definitely improves diagnostic accuracy and treatment planning. With AI now incorporated into anterior segment imagings, angle analysis is very convenient, very feasible and objective. And if you combine multiple modes of investigations, gonioscopy, OCT and or UBM and or Schlemflug imaging, then it will definitely give you a more comprehensive understanding of angle dynamics as well as the overall glaucoma pathophysiology. Thank you.
Thank you, Purvi, for summarizing the whole session. Any questions from the audience? We can take it now for anybody. Yes, sir.
What is the cutoff for the lens wall when you consider the patient for cataract surgery?
Purvi, would you like to say?
Actually, there is no cutoff. It is an individual measurement, and it basically just tells you how much the lens protrudes into the anterior chamber. So basically, it's a subjective evaluation. You just calculate and see whether it is contributing to the angle closure component or not.
Okay. And what about the mix mechanism? Sometimes when we see the lens vault is also there and there is a pupillary block mechanism is there. So should we go for the PI first and then decide, or like how you approach this?
Overall, most of the glaucoma specialists feel that every eye of angle closure does have some element of pupillary block. So the first step would be doing a PI. After that, you re-evaluate, repeat the imaging, repeat the gonioscopy, repeat the IOP. If you feel that the lens vault is significant, then you can go for cataract surgery. And of course, if the trabecular meshwork has been already damaged beyond repair and there is a true mixed mechanism type of a glaucoma, then you would treat it as an open angle glaucoma and proceed likewise. So it has to be a stepwise algorithm that you need to follow.
By doing the laser PI, you can also prophylactically prevent the malignant glaucoma after cataract surgery. So that may be of help.
Okay, thank you.
Any more questions?
Is there any role of ocular massage after TAF for reviving the
Yes, sir. You can do the imaging. By doing the ocular massage, there is a temporary opening, but it may not last longer. For few hours, you can have a advantage of pushing the aqueous into the bleb area. By doing the releasable suture technique, at least you will have an open apical area through which the aqueous is going on the posterior side, and it is a permanent effect.
If in the immediate post-operative period, for second or third day, you see that the bleb is wet, and then you do the massage, that there is a opposition of that flap or superficial flap that will open up and that will work. So aqueous will go from that passage and it will work.
The thing is, actually, after you have confirmed that the digital massage is working, you have to advise the patient to continue the massage at home. That is important.
Any role of 5-fluorouracil used in the post-operative period for trabecular?
5-fluorouracil.
We are not using now. You are using?
Intraoperatively, mitomycin
Nee,
C.
Post-operative.
Post-operatively,
Post-operative.
we have done one study in our case. It was a painful for the patient after second or third injection, and
Fibrosis.
fibrosis is going to happen. So needling and 5F you can do together. Thank you. Dr. Sood, would you like to comment on this?
5FU is being used, and post-operatively, the painful part in the fibrosis. So if you give it, say, at 6 o'clock position initially, then you go 1 clock hour up and on either side. So this is how it is, and you stay away from the bleb because 5-fluorouracil has its own problems, and that's corneal toxicity is much more common with 5-FU usage. The only advantage of 5-FU is that some of us can give it in the OPD when we are doing it. So when the 5-fluorouracil study came, they tried to get blebs which were not functioning well to function again by trying to reduce the fibrosis. So typically start at 6 o'clock, your first injection. Protocol is not defined. Some people will give morning and evening for 3 days and then reduce it further, but one injection at 6 o'clock, next day you could give it at 7 o'clock, next day you could give it at 5 o'clock. So you keep coming 1 clock hour up, and usually, as I said, there's no defined protocol left anymore, but 5 to 6 injections are what people normally try when they do this.
The corneal staining positive SPK after 5FU has to be looked every follow-up visit before you give the second, because that was considered where you have to stop giving the 5FU corneal toxicity. So, thank you very much to all of you for being here. I was not expecting audience here. Thank you.